Hi, I'm Sarah. Today I'm going to be giving a haematology update. So I recently attended the joint OAA and BSH meeting, which was brilliant. So I'm going to give a potted summary of my take-home points. There's quite a lot to cover, so I'm going to park talking about valvular heart disease and sickle cell anemia today. I've put a QR code at the top of this slide, which will link you to my notes, which were fairly in-depth during the meeting. Right, so let's kick off with thrombocytopenia in pregnancy. So it is common, it occurs in between 6 to 10% of pregnancies. The most common cause is gestational thrombocytopenia, which typically presents in the latter half of pregnancy. The second most common cause is a thrombocytopenia due to hypertensive diseases of pregnancy, so PET or HELP. This again typically presents in the latter half of pregnancy, so the gestation of onset is important. So a thrombocytopenia at booking is rare. If we have a look at the data on this slide, it's taken from Oxford from almost 12,000 pregnancies between 2015 and 2016. We can see that of these women, less than 0.2% had a platelet count of less than 150 at booking. The most common cause for a low platelet count at booking is ITP. So my take-home message was that thrombocytopenia, which is picked up during the first trimester, even if it's mild, is concerning and needs to be referred to haematology, whereas a platelet count of a similar level, which presents after 32 weeks, may not necessarily need to be referred on to haematology. So now talking about microangiopathic hemolytic anemias in pregnancy. So this slide shows onset by gestation, which can help disentangle and differentiate the different anemias. So we know that preeclampsia and HELP tends to be late onset or postpartum. Hemolytic uremic syndrome tends to also typically present postpartum. TTP, which is definitely a diagnosis not to be missed. Delayed treatment has a very high mortality, can present at any stage during pregnancy. I'm going to talk a little bit more about this on a later slide. So we've already talked a little bit about gestational thrombocytopenia. So we know that it's common, we know that it presents late. It typically has a mild course and is often asymptomatic. Most women have a platelet count greater than 70, and 70% of them have a platelet count which is greater than 130. The platelet count will typically have normalised by 7 days postpartum. They tend to not to have a history of thrombocytopenia outside of pregnancy, and it's not associated with a fetal thrombocytopenia. ITP, by contrast, we've already talked about the fact that it's the most common cause for a thrombocytopenia during the first trimester. However, it can occur during any trimester. The platelet count is low, it's typically less than 100. It can occur outside of pregnancy. It often results in a neonatal thrombocytopenia. It may recur in subsequent pregnancies. In terms of management, these ladies need to be monitored at least 4 weekly. The first line of treatment is steroids. The second line of treatment is IV immunoglobulin therapy, which is often poorly tolerated. It has a lot of side effects, which can range from headaches to aseptic meningitis. However, the combination of steroids and IVIG has a very good response rate of over 80%. And just of note that the symptoms of thrombocytopenia tend not to present until platelets are very low. So we're talking about platelet counts of less than 10. So what we want to know is, when is it safe for us to do a spinal or an epidural? So there are recommendations made by the International Working Group Consensus on ITP in 2019. So broadly, neuraxial techniques are safe if the platelet count is greater than 70, unsafe if it's less than 50, and a platelet count of 50 to 70 is a grey area and is a balance of risks. So what I think is a key message is that platelet function is more important than platelet number. So it's really important to consider what the underlying condition is that's causing the thrombocytopenia. So as a rule of thumb, if there's impaired production of platelets from the bone marrow, then you're more likely to have impaired platelet function. However, with certain conditions, although your absolute number of platelets might be low, you actually have heightened platelet activity. So you have heightened activity in ITP, TTP, PET, HELP, antiphospholipid syndrome. So questions that were asked were, is there a role for TEG or ROTEM in determining platelet function? So currently there is not enough evidence to recommend the use of VHAs as an independent predictor of platelet function, but watch this space. Can we use different cutoffs for epidurals versus spinals? So again, they say there's not enough evidence to recommend different cutoffs, but it was noted that the haematology guidance for performance of an LP for patients needing chemo is a platelet count greater than 40, which could be considered comparable to a spinal. Is there a role for platelet transfusions? There was a Cochrane review, however, it was based on quite low quality evidence, so no recommendations were made. And aspirin, so there's sufficient evidence to show that low dose aspirin is safe. However, we're more commonly giving higher doses now, so 150 milligrams of aspirin routinely, and there's actually no evidence to show that these higher doses are safe. So we don't know how valid these old studies are. So next I'm going to talk about one of the most dreaded complications, the incidence of spinal hematomas. So the incidence is much higher than traditionally quoted. So population incidence used to be quoted as 1 in 150,000 for epidurals and 1 in 220,000 for spinal anaesthetics. However, more recent studies have suggested that the incidence is much higher, even as high as 1 in 3,000. So the range was between 1 in 3,000 to 1 in 20,000. It's thought that the introduction of low molecular weight heparins is probably responsible for this spike in the incidence. The elderly are the most at risk. Thankfully, the incidence is much lower in pregnant women. However, the risk is significantly increased where there is either coagulopathy or the use of anticoagulants. I'm not going to go into detail about bleeding disorders in pregnancy other than to signpost to the RCOG Green Top guidance regarding their management. So, the most common bleeding disorder label that is applied in haematology clinic is bleeding of unknown origin, which 60% of patients end up with that label. So these are the patients that we will be encountering most frequently in pregnancy. However, the fact that they don't have a formal diagnosis or a specific diagnosis does not mean that they are a reduced risk of bleeding. They still have the same clinical risk of bleeding, and they typically fall within the mild to moderate bleeding risk group. So the study on this slide was a retrospective analysis of the advice given regarding neuraxial anaesthesia from haematologists regarding these patients, and unsurprisingly it showed that it tended to be conservative, with 88% of delivery plans it was advised to avoid neuraxial anaesthesia, and the remaining 12% recommended just a single pass spinal. So this raised the question of how do we decide what's an acceptable risk, and what do we do when we don't know what the risk is. So this on the box on the right is taken from a talk given by Will Lester, which is the factors which influence him and nudge him towards recommending to do a spinal. So next I'm going to move on to TMAs, or thrombotic microangiopathies in pregnancy. So what are TMAs? It refers to a pattern of endothelial cell injury of variable severity, which can lead to a classic triad of peripheral thrombocytopenia and mechanical hemolytic anemia and organ dysfunction. So it particularly affects the CNS, so it can present with altered level of consciousness or seizures, the kidneys resulting in an AKI, or the heart leading to raised troponin or ischemia. Pregnancy and postpartum are high risk periods for many TMAs. It is a clinical diagnosis, with a combination of a thrombocytopenia and red cell fragmentation. So typically you find a platelet count of less than 100, a hemoglobin of less than 100, and an LDH, which is 1.5 times the upper limit of normal. You get associated organ dysfunction. So all TMAs are associated with placental ischemia or an infarction. The pregnancy-related TMAs are PET and HELP, and the pregnancy-associated TMAs are TTP and complement-mediated, otherwise known as atypical hemolytic uremic syndrome. This is a bit of a busy table. It's not there for the details, it's there to illustrate that there is a large crossover between the different TMAs, so it can be quite difficult to distinguish between them. We've already looked at a chart about the gestation of onset. So classically, hemolytic uremic syndrome presents with a renal phenotype, whereas TTP presents with a cardiac or neurological symptoms. However, this cannot be relied upon to distinguish between them. So how do we differentiate? So firstly, by frequency, PET is common, affecting up to 1 in 20 pregnancies. HELP is less common, but still affects 1 in 1,000. TTP and HUS are rarer, but not to be missed. The gestation of pregnancy can also give us a clue. So HUS, we've already mentioned about the fact that it's typically diagnosed postpartum. PET and HELP are present in the latter stages of pregnancy, and TTP can present at any stage. So how do we manage them? So if the platelet count is significantly low, so we're talking about platelet counts of less than 50, then the rarer TMA, so TTP and hemolytic uremic syndrome, need to be ruled out. They are medical emergencies. So TTP is a commissioned service across England, so you contact your nearest TMA centre, which is here. And so for PET and HELP, the definitive treatment is delivery, controlling the blood pressure, monitoring for pregnancy complications. The management for TTP or hemolytic uremic syndrome is plasma exchange. So before plasma exchange happens, a blood sample is taken, which is post-plasma exchange tested for Adam's TS13 activity levels. And that distinguishes between TTP and hemolytic uremic syndrome. So in TTP, there is classically an Adams TS13 level of less than 20%. And it has a response rate of 80 to 90% for treatment. If it is, if HUS is diagnosed, then they're treated using a complement inhibitor such as eculizumab. So the next slide shows the management of ITTP in subsequent pregnancies, but I'm going to skip on through that in the interests of time. So PET is still a clinical diagnosis, so there's still potential for diagnostic inaccuracies. Soluble FLT1 to placental growth factor ratios are increasingly being used for diagnosis as they reflect the angiogenic imbalance and the underlying pathophysiology of the condition. So placental growth factor is pro-angiogenic, whereas soluble FLT1 is anti-angiogenic, so the ratio is used. So moving on to PPH. Despite numerous interventions over the past decade, data from the Embrace reports show that the maternal death rate has not improved. And sadly, that most women who die from PPH in the reports have either untreated or delayed treatment of their coagulopathy. So why is it so difficult to treat PPH coagulopathy? So the reason that it's difficult to treat is that actually most women don't have coagulopathy. So I'm sure everybody's familiar with the OBS Cymru study, which is a QIP that's been running in Wales. And this is some of their data, which you can link from the QR code above. So this table shows all the women that had a PPH within their study, and the vast majority of women had a fibrinogen of greater than 4.5, so did not meet the definition of having a coagulopathy, and only 5% went on to develop a coagulopathy. So that's 22 out of 459. as defined by a fibrinogen of less than 2. So how do we predict who is going to develop coagulopathy? Well, we know that etiology is important, so trauma has a much lower incidence of coagulopathy. Abruption has a higher incidence, which is closer to about 20%, and amniotic fluid embolism coagulopathy is universal as it's diagnostic. The volume lost is important. So in the major obstetric hemorrhage group, so that's a blood loss of greater than 2.5 litres, 17% went on to develop a coagulopathy, as opposed to 5% overall. And also the instance of fibrinogen deficiency. So we already know that there's a good correlation between initial fibrinogen concentration and likelihood of a bleed, with previous studies showing that fibrinogen less than 2 has a 100% positive predictive value for progression to a PPH. So in the next few slides, I'm going to be referencing this article, which was released earlier in the year, which is from the OBS-Cymru group. It's a prospective cohort study from a population of almost 12,000 pregnancies, and 518 were recruited as they had a PPH of greater than a litre. And that essentially routine coagulation and ROTEM results were collated from these deliveries, and then coagulation factor assays were measured. Markers of fibrinolysis were collected, so D-dimers and PAPs, so plasmin antiplasmin complexes. And it showed that women with very large bleeds, so we're talking about greater than 3 litres, showed evidence of a dilutional coagulopathy, although hemostatic impairment was uncommon. But the kind of cornerstone finding is that there was this subgroup of 12 women who had a very distinct coagulopathy, which was characterised by massive fibrinolysis. And a new term was coined, which was acute obstetric coagulopathy. Apologies for the meowing in the background. So this slide shows the results from the control group, which demonstrates, unsurprisingly, the enhanced coagulation effect in pregnancy. So the only clotting factor that we see drop below the normal range is factor 13. So the red bars are the non-pregnant normal ranges, and we see enhanced thrombin generation. Then when we move on to have a look at coagulopathy during PPH, so the coagulation factors were assayed by volume of bleed. So we see that the APT and platelet counts did not become abnormal in most patients until there was an absolutely catastrophic bleed. So the red line is running down the middle, is bleeds that are over 4 litres plus. And then again with clotting factors, there's only clotting factors 2 and 7, which are demonstrated here, although it correlates out to all of the other clotting factors as well. So with the clotting factors, again, they sequentially dropped, which was thought to be secondary to perhaps a dilutional effect. And again, they only fell outside the normal range when you're having bleeds which are greater than 4 litres. So this is the subgroup analysis where of the 12 women who developed a distinct coagulopathy. So fibrinolysis was defined using PAPs. I've put the fibrinolysis pathway in the middle so you can see. So some women had high PAPs, but there was a subgroup of women who had extremely high PAPs. So for context, if you have a look at the graph on the right, this is taken from trauma-associated hemorrhage. So you can see that in trauma, the highest PAP levels that are seen are close to 15,000. Whereas the women in this study had PAP levels which were of a completely different order of magnitude. So we're talking about PAPs which were going up to 500,000. Extremely high. So acute obstetric coagulopathy was defined as a PAP, so plasmin antiplasmin complex, which is greater than 40,000 when first tested. So AOC coagulopathy is characterised by massive fibrinolysis, so increased D-dimers, hypofibrinogenemia, but also dysfibrinogenemia. So you have low levels of fibrinogen, but it's also not working very well. Reduced factor 5 and factor 8, and increased activated protein C. So what do we know? We know that it was rare, so there were only 12 ladies, so it reflected about 2% of the PPH group and out of 1 in 1,000 pregnancies in the study. In terms of their deliveries, it was 50-50 split, so 6 had a vaginal delivery, 6 had a C-section, and almost all were emergencies. In terms of pregnancy outcome, it was very poor, so over 50% had a stillbirth or an early neonatal death. In terms of the causes of their hemorrhage, 7 was due to abruption AFE or coagulopathy, whereas 5, it was atony surgical or a retained placenta. The final slide on this study is just of this subgroup further analysis of their lab findings, which I've summarised already. So they had increased D-dimers, and then they had reduced fibrinogen levels, but also the fibrinogen function was inhibited as well. There's a lot more to say on this subject, but I'm trying to keep it as brief as I possibly can. I'm not going to talk about sickle cell anemia today, so I'm going to call it to a close. So thank you very much for listening, and I would greatly appreciate it if you can complete my feedback form. I'm booked in for a journal club session in early January, so if there's any of these topics that you'd like me to expand upon, please leave a note in the feedback. Thank you very much.